All right, now let me back up a bit. After we have ascertained the patient's level of consciousness, we need to assess the patient's airway, and that would be upper and lower airway. If the patient is alert and able to answer questions, the airway is open. In an unconscious patient, you must open the airway, and this is something you know by now. So if the patient is not responding, we're gonna have to put in some work to keep that airway patent. Inspect the airway for foreign bodies or secretions. Clear the airway as needed. You may need to insert an airway adjunct based on your assessment. Assess breathing. So assess the rate and quality of breathing. If the patient is unconscious, use a look, listen, and feel approach, and you simultaneously check for that pulse. Check for foreign objects and remove them. If the patient is not breathing, open the airway, perform rescue breath. So if the patient is talking to you, just observe the patient's breathing rate. So if the patient is communicating, observe the patient's breathing pattern, check the rate and quality of breathing, and if something is wrong and you have treatment available, provide treatment, and that treatment is going to be oxygen administration, whether low or high flow. If the patient is not talking, so if the patient is not responding, position the airway, check if it's clear, look, listen, feel. So use one hand to maintain the head tilt and the other to check that carotid pulse. If there is a pulse and there is no chest rise, check the rate and quality of the pulse. If you can see chest rise, so if the patient is unresponsive and there is chest rise, evaluate the chest rise, rate and quality, and then evaluate the pulse. So once you can see breathing, check breathing before circulation or before pulse. If you cannot see any breathing pattern, then you check the pulse or check circulation. Now, if a patient has a pulse and is not ventilating, you must ventilate for that patient. And we went over this yesterday. So it's 1 breath every 5 to 6 seconds for an adult, 1 breath every 3 to 5 seconds for a child. The younger the child, the closer you are to that 3 seconds. For your adult, you tend to want to go more to the 6 seconds. Now, once you have assessed upper and lower airway and you have provided the most appropriate interventions, then the next phase of your assessment is going to be circulation. Now, if the patient is unconscious, we know this by now, we check the pulse that is closer to the brain. That would be the carotid pulse. If the patient is communicating or is conscious, then you will check the radial pulse. So once the patient is not talking, you go for the pulse that's closest to the brain. If the patient is not talking, then you go for your peripheral pulses, your radial pulses. Check the patient for severe external bleeding. Always look for signs of bleeding, external bleeding, whether it's a trauma or medical patient. Very important for your trauma, but don't neglect that assessment for your medical patients. Medical patients can bleed. So look for signs of bleeding. If bleeding is present and it is excessive, you address it. And in some circumstances, you may have to deal with blood loss before you even manage airway because it's excessive. Assess the patient's skin color and temperature. So your circulation assessment involves 1, checking the pulse, 2, checking for external blood loss or signs of bleeding, and 3, looking at the color of the skin and the temperature of the skin. And when you're going to look at the patient for color changes, use the palm of the hands, look for changes. So normally the palm should be nice and pink. That suggests good circulation. When a patient is critically ill or injured, it can become very pale, or it can become grayish or bluish. Now, when you see pale skin, if you see pale palms, the palms look very pale, it's a circulation problem. If the skin starts to have a dark grayish color or it looks blue, that's an oxygenation problem. When a patient is going into shock, you will see pale skin before you see blue skin or cyanosis. So cyanosis is bad. If the skin look blue, palms look blue, lips look grayish or blue, your patient in trouble. That patient is in serious trouble. Now, the temperature here is not an exact reading, so we're not trying to obtain an exact temperature for this patient. All we're trying to determine is, does this patient feel excessively hot, cold, or nice and warm, or warm and dry, right? We're really trying to determine if the patient is going into shock, if the circulatory system has been compromised. So we don't need an exact temperature. We just want to know if the skin feels cool, clammy, warm, dry, excessively hot. And if it's cool and clammy, sweaty, excessively sweaty, then, or it feels sticky or mottled, that's indicative of shock being there or present. If it's excessively hot and dry, or excessively hot and excessively dry, then you're thinking about an infectious or inflammatory process, and you're thinking about dehydration. It can all, the palms can also have a yellowish or orange-like color, and if it looks that way, it is an indication, it would be linked to liver issues or kidney problems. So if you see yellow or orange looking skin, you want to think about liver issues or kidney problems. So again, with your circulation, you check pulse, can be radial or carotid. It depends on whether or not the patient is responsive. You look for signs of external bleeding. If present, you address it appropriately, and you look at the color of the patient's skin and the temperature. And there are your pulse points. And you always check for the carotid pulse on the side that's closer to you. So you put your 2 fingers on the trachea and then slide them into the groove and create pressure on that carotid pulse. Do not palpate both carotid pulse at the same time. You're going to cut off the blood flow to the brain. Patient will lose consciousness. For the radial pulse, it's the pulse that is in line with the thumb, and you want to put pressure on that pulse where it runs directly over the bone. And that's for your patient that is communicating. Now, descriptions of skin color. The skin can be pale whitish, indicating decreased circulation to that part of the body. Your mic is open, Mr. Gordon. Close that mic. It's creating feedback. Thanks. So pale skin, whitish, indicating decreased circulation to that part of the body or to all of the body. So pale skin is a circulation issue. Flushed, which is reddish skin, this indicates excessive circulation to that part of the body, and that is linked to inflammatory or infectious processes occurring in the body. Blue skin or cyanotic skin indicates a oxygenation problem, and it can also indicate an airway issue. Yellow skin is indicating liver problems, or it can be the patient is having an issue with their kidneys. Normal skin should be nice and pink and warm and dry in temperature. Now, after you have completed your ABC's assessment, ensure that any important findings in your assessment is documented. So it must be documented, and there are standard formats for documentation. It can be chronological order, it can be the chart method, or it can be the SOAP method. Your organization will decide which method you use. I prefer the chart method, but whichever method the organization dictates, that's what I will use. Now, your report should entail what the patient complained of. So any report that you're going to give, it should have what the patient complained of, what you did based on your assessment findings or observations, how the patient responded to your treatment, right? And whether or not you consider the patient to be critical. So what did the patient complain of? What did you find based on your observation and assessment? How did you manage the patient? And what are your considerations? Do you consider this patient to be critical? Do you think the patient require immediate transport? These things should be in your report. So update responding EMS units, elements of the report, the exact age of the patient, if you can get it at this point, and sex of the patient chief complaint, their level of responsiveness, the status of airway, breathing, and circulation. Try to perform all 4 steps of the primary assessment quickly as you make contact with the patient. So, your primary assessment is you form a general impression of the patient and the environment that the patient is in. Consider the patient's gender, skin color, level of distress, developmental age, the position that the patient is in, whether life-threatening issues are present. Then assess the patient's level of consciousness using your AVPU. Based on the patient interaction, assess upper airway and lower airway. If any management is required, provide that management once it's within your scope of practice. After you have covered ABCs, after you've covered AB, then it's circulation. And for the upper airway, your assessment is you position, you ensure the upper airway is clear, and you look, listen, feel. For your lower airway assessment, you check rate and quality, and you count the rise and fall of the chest for 1 minute. Look at the quality of the patient's breathing. Is it regular? Is there muscle use? Is there abnormal sounds? Can you see chest rise bilaterally? If you have a pulse ox, put it on. Any issues detected, treat accordingly. For upper airway management, it's going to be your airway adjuncts, your pocket mask, your suction device, or your BVM and BVM. For your lower airway, once it's within your organization and you have had appropriate workshops, if oxygen is required administer oxygen either at low flow or high flow. Once you have completed that portion of your assessment, the next phase is circulation. We want to know the pulse, where if the pulse is present, what's the rate of that pulse? Is it fast or slow? Is it strong? Is it weak? Is it regular? We want to know if the patient is bleeding anywhere. If bleeding is present externally and it's excessive, it has to be addressed appropriately. Then we want to look at the skin color and the temperature. And this portion of your assessment should be completed within 6 minutes. So it shouldn't take you more than 6 minutes to complete a primary assessment. And once you have completed the ABCs, we need to relay any important information to EMS units prior to their arrival and when they arrive on location. Now, after we have completed the primary assessment, the next phase of the assessment process is history taking. So once you have managed your ABCs, is the patient talking? Yes, get information from the patient. So once you complete ABCs and your patient is talking, get some info. So investigate the chief complaint. Do not allow a conscious patient's comments to distract you. The purpose of obtaining a history is to gather a systematic account of past medical conditions, illnesses, and injuries. Determine the events leading up to the present medical situation. Determine the signs and symptoms of the current condition. So question the patient in a clear and systematic manner. Learn the relevant facts, including serious injuries, illnesses, or surgeries. Is the patient on any prescriptive medicine? Is the patient taking over-the-counter medication? Is the patient herbal medicine? Is the patient allergic to any medicine, food, or does the patient have seasonal allergies? These are all important questions. Now, in EMS, we use the sample history or the sample acronym to obtain history. So just follow the sample. The S is for signs and symptoms, and I've already explained what signs and symptoms are. Now, you're not going to ask a patient, ma'am or sir, what is your signs and symptoms? Right? Not going to ask the patient that. Signs is what you can see, hear, smell, what can be measured. Symptoms is what the patient is complaining of. They're complaining of headache, nausea, dizziness, complaining of chest pain and difficulty breathing, complaining of not being able to lie flat, feel like you're drowning, coughing up mucus. These would be your signs and symptoms. Don't ask the patient to tell you what the signs and symptoms are. So that's your S. A is for allergies. Ma'am, excuse me. Ma'am, sir, are you allergic to any medication? Are you allergic to any food, any herbal medication, anything like that? No allergies? No? Okay. So the A is for allergies. M is for medication. Mom, sir, are you currently taking any medication? If they say yes, okay, which medication are you currently taking? Why are you taking that particular medication? Is it readily accessible? Can I have a look at it, please? Did you take any of this medication prior to having the chest pain? Did it work? So you need to also know when to follow up. So M is medication. P is pertinent past medical history. So do you have any medical history that you want to tell me about? You have any history of issues with your circulation, Any issues with your blood pressure? Any issues with your blood sugar? Have you ever had this issue in the past? Was it as bad as this? Was it as bad as it is now? So again, need to know when to follow up. So pertinent past medical history. That's the P. L, last oral intake. What was the last thing you had to eat? When did you eat? What time was that? So what was the last thing you had to eat? How long ago was that? Give me a time. All right. And E is events leading up to, right? So, okay, sir, ma'am, what exactly were you doing when you started to have trouble breathing? What exactly were you doing when you started to feel lightheaded and feel like you were going to pass out? What exactly were you doing when you started to have the abdominal discomfort? So events leading up to, and that's your sample history. So this is the acronym you will use to obtain your history. So it provides a framework to ask further questions of the patient. Ask the patient one question. L is last oral intake. Ask the patient one question at a time. Listen carefully and use good eye contact. If the patient is unconscious or senile, a family member or friend may be able to help. Communicate this information to other EMS personnel. So S is signs and symptoms. A, allergies. M, medication. P, past pertinent medical history. L, last oral intake. E, events leading up to. So that's your sample acronym. You don't need to write off the information off the slide. I will send the PowerPoints if you don't have access to the platform as yet. So don't try and write off the information when I'm giving the lecture. You need to focus on what it is I'm saying at this point. You will have access to the PowerPoints. All right, now after we have completed the history taking phase, and points to note, we can obtain history directly from the patient. We can get it from family members, we can get it from bystanders, we can look at the scene or the environment, we can look at the patient for clues. If you're unable to obtain any information from the patient, it would be important to look at their pupil reaction. It would be important to check their blood sugar, and it would be important to look at their pulse oximetry. And these are things you can relay to the responding unit. Weren't able to get any appropriate history, so might want to check pupils and blood sugar and pulse oximetry when you get on location. That's a good EMR. That's a solid EMR. Now, after your history taking phase, the next phase of your patient assessment algorithm is the secondary assessment. Now, the secondary assessment is done to assess non-life-threatening conditions. That's the purpose of secondary assessment for EMRs. It's a little bit different for EMTs, but for EMRs, it's for a stable patient. The physical examination helps you to locate and begin initial management of signs and symptoms of illnesses, or injuries. A sign is something about the patient you can see or feel for yourself. A symptom is something the patient tells you about his or her condition. A secondary assessment requires you to systematically assess the patient. You look and feel for signs of injury. So if you suspect trauma, to the patient and the patient is not unstable, you will expose and you're looking for your dots, deformities, open wounds or injuries, sorry. T is tenderness, S swelling, dots. That's the acronym. For the full body assessment, can be done whether the patient is conscious or unconscious. So what that simply means is if you have a patient that is not communicating and the mechanism of injury is significant, then you look for dots from head to toe. If they are not talking and the MOI is significant, you look for dots from head to toe, full body assessment. If they are communicating and there is an isolated injury, you look for dots to the isolated area of the body. So if it's the arm injured, look for dots to the arm. If it's the leg injured, look for dots to the leg. If there is a diffuse mechanism, look for dots to the entire body. Now, assume that all unconscious injured patients have spinal injuries. Stabilize the head and spine to minimize movement during the patient examination. We'll show you how to do that to some extent. Now, the focus assessment. Perform on patients who have sustained non-significant MOIs or a responsive medical patient. So if the patient can talk to you and it's a trauma patient and the injury is isolated, then we do a focused assessment. If the patient is a responsive medical patient, we focus on the patient's chief complaint. Now, during your focus assessment, you're going to focus on any immediate problems. That's where your focus should be. What are the issues? What can I do about these issues that are present? So, assess the vital signs. The normal adult resting respiratory rate is 12 to 20 breaths per minute. So, count the patient's breath for 1 minute and check the breathing rate and quality. So rate and quality. How many breaths per minute? Is it regular? Is there muscle use? Is there abnormal sounds? Can you see good chest rise or visible chest rise? For the pulse, indicates the speed and force of the heartbeat. Take the radial pulse if a patient is conscious. Take the carotid pulse if the patient is unresponsive or unconscious. So take the carotid pulse of an unconscious patient. When examining an infant, you will use the brachial pulse. In a normal adult, the resting pulse rate is 60 to 100 beats per minute. Determine the rhythm and quality. So you want to know if the pulse is fast or slow. Is it normal or within normal range? Is it consistent? Is it weak or strong? And note the side that you obtain the rate on. So if you got the rate on the right radial pulse, put that in your report. Pulse rate was obtained via the right radial pulse. And note the time that you complete your vital signs. So vital signs must be done after primary assessment and management. And what you're doing when you obtain your vital signs at this point is to determine if your interventions have worked. Is the patient getting better or worse? And if you haven't provided any intervention, it's going to tell you if your patient is trending up or trending down. Capillary refill, ability of the circulatory system to return blood to the capillary vessels. So it's an assessment where you squeeze the nail bed until it gets pale, kind of pale, not completely pale, but you're squeezing the blood out of the capillary beds and then you're going to count how long it takes to return back to its pink color, and it shouldn't be outside of 2 seconds. It should be less than 2 seconds. It's a circulation assessment that it's specific to the pediatric population or kids. So squeeze the patient's nail bed firmly between your thumb and forefinger until the nail bed looks pale. Release the pressure and count to 2 seconds. The patient's nail bed should return to pink in this time, indicating a normal capillary refill. So it should not exceed 2 seconds. Now, blood pressure. As I say, I'm not going to be teaching this particular group how to obtain a blood pressure. So not going to spend a lot of time on this, but just understand that the blood pressure is written as a fraction. And as you can see here, for this particular blood pressure, 140/90, the 140 represents what we call the systolic blood pressure. So the 140 represents the systolic pressure. And the systolic pressure is a representation of ventricular contraction. So it's when the ventricles contract and the blood is pushed out of the ventricles, we get the systolic pressure when the ventricles contract. The bottom number, which is a 90, is the diastolic pressure. And the diastolic pressure is obtained when the ventricles relax. This is when the blood has been pushed out by the ventricles relax, and the blood is flowing against the pressure inside the arteries. That's the diastolic pressure. Hypertension exists when the blood pressure remains greater than 140/90. So ideally, blood pressure should be 120/80. The systolic tends to go up as we get older if we're not in good shape. A patient who has a systolic, which is the top number, that is 160 or higher, and a bottom number, which is a diastolic, that is 110 or higher, is at risk for stroke. So if that person has a blood pressure of 160 or higher over 110 or higher, the patient can get a stroke. They should not be working. They need medication. All right, now skin condition. Check for skin color, temperature, and moisture. Normal body temperature is 98.6 degrees Fahrenheit or 37 degrees Celsius. Normal skin conditions are described as warm, pink, and dry. Pupil size and reactivity is a good assessment to be conducted. And you would need a pen light to do that. Now, examine each eye to detect signs of head injury, stroke, or drug overdose. So shining a light in the pupil can tell us a lot about the brain. Now, when a light is shined into the pupil, the normal reaction is for the pupils to constrict. Now, if a light is shined into the pupils, so if a pen light is shined into the pupils and they look tiny like this, you see pinpoint pupils, that's an indication of a drug overdose, specifically narcotic overdose, which decreases brain function. You can shine a light into the pupil and one looks normal and one looks dilated like this one. Now, and we call that unequal pupils. When the pupil looks like that, where it's dilated and the other one looks normal or the same, it can indicate that pressure is building up inside of the brain. So it's an indication that there might be a head injury present, unless the patient was born with the pupils like that. Some persons are born with unequal pupils. So the pupils can tell you a lot about the brain. Now, a patient can have fixed and dilated pupils, meaning both pupils are fixed and dilated, meaning when you shine the light, nothing happens. Can be that the patient is dead, or can be that the patient overdose on seizure type meds. So the pupils can tell us a great deal about brain function. So pupil size and reactivity. Determine whether the pupils are of equal size and whether both react when light is shone into them. You're going to need a pen light for that. Pupils of unequal size can indicate a stroke or injury to the brain. Pupils may remain constricted in a person who is taking narcotics. Dilated pupils indicate a relaxed or unconscious state, and it can be linked to specific overdose. Now, level of responsiveness, observe and note any changes that occur between the time of arrival and the time you turn over the patient's care to higher level personnel. Use the AVPU scale. And the final phase of the patient assessment sequence is the reassessment. If you need to continue to care for the patient, some parts of the patient assessment may need to be repeated, specifically your primary assessment. And that's really what a reassessment is. You're repeating your primary assessment. So recheck the patient's level of responsiveness, reassess ABCs, think about your interventions, make any adjustments as needed once it's within your scope of practice. Continue to maintain an open airway and to monitor breathing and pulse for rate and quality. Observe the patient's skin color and temperature. Reassess the patient's blood pressure. Not going to be teaching you blood pressure. Reassess the chief complaint. Recheck the effectiveness of treatment. If the patient's status changes, determine whether you need to alter your care. So again, reassessment is simply you repeating your primary assessment. If the patient is critical, every 5 minutes. If the patient is stable, every 15 minutes. Identify and treat changes in the patient's condition. Reassess the patient. Reassess a stable patient every 15. If the patient is unstable, repeat reassessment every 5 minutes, and you continually monitor your patient. Always monitor your patient. And you're going to be providing a handoff report, and in your handoff report, this should include the age and sex of the patient, history of the incident, the patient's chief complaint, the patient's level of responsiveness, the status of the vital signs, results of secondary patient assessment, if you were able to conduct one. Any pertinent medical conditions, specifically your sample, should be relayed when handing over the patient, and any interventions that you provided should also be relayed, and the time that it was provided and how the patient responded to the intervention. Now, a word about medical and trauma patients. Patients can generally be classified in two main categories: those who have a sudden illness, which would be a medical patient, and those who have sustained trauma, that's your trauma patient. The patient assessment sequence can be used to examine patients who have experienced illnesses trauma, or a combination of both medical and traumatic issues. When examining medical patients, follow the basic assessment sequence. When caring for a trauma patient, perform a secondary assessment before taking the medical history. So when examining medical patients, follow your basic assessment sequence. When caring for a trauma patient, perform the secondary assessment before taking medical history. So in other words, if it's a medical patient, it is ABC's history. If it is a trauma patient, it is ABC's secondary assessment. So ABC's physical assessment of the injured part or the entire patient, and then history. Always avoid jumping to conclusions. Now, in summary, a complete patient assessment consists of 5 steps. Perform a scene size up, perform a primary assessment, obtain a patient's medical history, perform a secondary assessment, and provide reassessment. The scene size up is a general overview of the incident and its surroundings. During the primary assessment, determine and correct any life-threatening conditions. The steps of the primary assessment are to form a general impression of the patient, assess responsiveness, and perform a rapid scan that consists of checking and correcting problems with the patient's airway, breathing, and circulation. Finally, based on your assessment findings and treatment, you need to update EMS personnel when they arrive to take over the patient from you. A medical history provides a systematic account of the patient's past medical conditions, illnesses, and injuries to determine the signs and symptoms of the current condition. The secondary assessment of the patient consists of a full body assessment used to assess non-life-threatening conditions. If the patient is stable, repeat vital signs every 15 minutes. No, yes. If the patient is unstable, repeat the vital signs every 5 minutes, but you constantly monitor your patient. Provide a concise and accurate handoff report. Do not tell lies. Don't tell lies. So if you didn't do something, don't write that you did it. And it's a tendency for responders to do that because they want the report to look like it's properly completed. If you didn't do it, you just didn't do it. I've had patients where I was not able to do a full set of vitals because I was stuck controlling bleeding. I had a gunshot wound and it was bleeding. So you just didn't get to do it, and state in your report why. So if you weren't able to do something, state why. Don't tell any lies. And that would be the end of your patient assessment chapter.